Good afternoon, and welcome to today's presentation, Evidence-Based Guidelines 2, Specific EBGs for our core measures. My name is Valencia Harper, and I will be your facilitator today. At this time, all attendee lines are muted for this session to minimize background noise and distractions. We encourage your questions and input throughout this presentation. Please feel free to use the raise hand icon in your taskbar or submit questions and comments in the chat box provided. Today's presentation will include polling questions. We encourage everyone to participate as we value your interaction. Today's presentation will also be recorded and later uploaded to our HealthVisions Delmarva PTN YouTube channel. You may find the link on the flyer included in the invite to today's webinar. Today we are privileged to have 4 presenters from HealthVisions Delmarva presenting on the following topics of depression, diabetes, heart failure, and hospitalization. One of today's presenters is Cindy Eiseman. Cindy is the project manager for HealthVisions Delmarva, which is a practice transformation network working through the CMS Transforming Clinical Practice Initiative. Cindy has over 30 years of experience in healthcare, starting in the area of health information management and expanding her skills in areas of expertise to performance improvement, operations management, healthcare financing, and practice transformation. Before I introduce the other presenters, Cindy is going to briefly discuss an overview of today's presentation.
Hi, everybody, and thanks for joining us this afternoon. We have an information-packed webinar today. There's a lot more words than normal on our slides, but there's a lot more information to provide. And I just wanted to reiterate what Valencia said about being able to pull the handouts from the taskbar that you see on the right-hand side of your screen. Please do take the time to download those because they're formatted in a pretty nice format and make it easy for you to follow. So what are our questions to run on today? Well, first, we're going to do a very, very quick overview of why are evidence-based guidelines needed to improve health outcomes for our patients and our populations. And we're going to look at four specific areas. We're going to look at guidelines for depression, for heart failure, for obesity, and then for reducing rehospitalization or hospitalization for our chronic disease patients. Just a very, very brief reminder of why we're talking about evidence-based guidelines and how we want to think about them for use in our practices. Evidence-based practice is the integration of clinical expertise, but also patient values, research evidence, and then decision-making in patient care. Evidence-based guidelines is not a cookbook. It's not cookbook medicine. It's a framework for decision-making, and it's based on the combination of all 3 of those areas: clinical research, patient input, and provider expertise. So we rely on our guidelines, but we need our clinicians to use their expertise and to take into account our patients' values, needs, and preferences in the decision-making process. That being the foundation for what we're going to talk about today, we first will introduce our speakers, the rest of our speakers, and then we'll move on to our first polling question.
Colleen Davis has been practicing medicine as a physician assistant for over 14 years after completing a master's at Philadelphia University. Her work as a PA has been primarily in neurosurgery and emergency medicine. Through the course of her experience and building of relationships with physicians and practice managers, she developed her own consulting company, Pivotal Healthcare, and began assisting organizations with developing their medical neighborhoods and collaborative networks, as well as mergers and acquisitions, business development, and expansion. Her work has the focus of accomplishing and refining the organization goals in order to implement and achieve their model enterprise. Dr. Edward Sobel is a board-certified family practice physician, retired senior partner and family physician at Family Practice Associates, and a current senior attending staff member and executive committee member of the Department of Family and Community Medicine at Christiana Care Health System in Wilmington, Delaware. He is currently the medical director of HealthVisions Delmarva PTN, the Health Care Quality Improvement Program for Quality Insights of Delaware, and the Delaware Regional Extension Center. Dr. Sobel's awards include the Delaware Academy of Family Physicians, Family Physician of the Year, the Christiana Care Health System Preceptor of the Year, the Medical Society of Delaware Daniel A. Alvarez, MD Service Award for helping to implement over 1,000 physicians on electronic medical records. Dr. Blake Williamson is an experienced healthcare executive and physician with more than 20 years of experience creating innovative solutions to some of the toughest challenges in healthcare. Throughout his career, Dr. Williamson has cultivated a reputation for helping organizations understand and manage the risks associated with constant changes while delivering clinical business objectives on time and on budget. Based on his experiences as both a practicing physician and as a senior executive, he is able to understand all sides of a complex insurance hospital-physician relationship to help organizations create the infrastructure to improve quality and efficiency as it carries employers, health systems, and payers successfully into the future. So we're going to go ahead and launch our first polling question. And it reads, for my practice and my specialty, I have sourced and implemented evidence-based guidelines. I have sourced but not implemented evidence-based guidelines. I have not looked for evidence-based guidelines. We have about 21% that's voted so far. Over half have voted.
Always try to get to that 75%.
We're at about 71 right now, and looks like we're standing still there. So we have 50% have sourced and implemented evidence-based guidelines. 30% have sourced but not implemented evidence-based guidelines, and 18% have not looked for evidence-based guidelines.
Okay. So that gives us a good baseline for where we stand, and we've talked about this on previous webinars. It's something that our practice advisors are going to be looking at with each practice as we move forward to make sure that we are helping you to put those evidence-based guidelines into place. So without further ado, we're going to move to our first topic, and that is the management of depression. And our presenter on this topic is Dr. Blake Williamson. And Blake, go on ahead and let me know when you want me to move a slide.
All right. Well, the primary source for my remarks today is going to be a guideline from Intermountain Health on depression. And if you actually Google depression guidelines, you're not going to find this one. They've got it listed as a care process model. I would recommend all of the guidelines or care process models that they have, and they're on that link. There's about 75 different conditions. What I like about them is that they approach things from a team-based perspective, and I haven't seen a lot of guidelines that do that. So that's a good source for you for many guidelines. The other source that I'm using as a primary source is the U.S. Preventive Task Force guideline on use of the PHQ-9, and they've got a stratification tool that's pretty good. So just to start then, on the depression best practice, the pearls that sort of come out of this guideline are that, one, all patients should receive a PHQ-9 as a screening tool, and then they do recommend that on a regular basis, all patients have that administered. They don't define exactly what that is, but they, you know, if you find someone that's depressed based on the PHQ-9, there are some severity levels that can be drawn from the PHQ-9. And the recommendation is that you stratify those and manage them for an appropriate level. You should assess comorbid conditions along with that. That would include things like suicide, bipolar disease, history of sexual abuse, substance abuse, any medical comorbidities or precipitating medical conditions, things like that. And then in general, it's recommended that you treat as appropriate to the guidelines that are present there, and they have fairly extensive guidelines related to various antidepressants. first and, other lines, that you monitor those on an ongoing basis for response and adjust your treatment as necessary, and that you aim for a full remission as you move forward. And they do recommend regular rescreening of these patients that are on treatment to see how they're doing using the PHQ-9. So go ahead, Cindy. The PHQ-9, you can be used to stratify that into various severity levels. For mild depression, they're recommending an antidepressant or psychotherapy, along with some patient education. In the moderate section, they recommend the same thing, but you may want to combine psychotherapy and an antidepressant. And you should probably start considering some care management processes and whether or not it's appropriate for this particular patient to integrate other community services in the mental health area, like social service or other things that you might have in your particular community. And then for the more severe depressed patient, a similar sort of thing, but making sure that you are using care management as well as the mental health integration thing. And then measuring a response on a regular basis to see where things are at. Go ahead, Cindy. So for most patients, they recommend that you follow these patients up in 2 weeks just to see if things are going well. You can do that either by phone or appointment, just to check for side effects and to reinforce any education. And then you can see on a 4-week basis if things are going well, regular follow-up with a repeat PHQ-9. Once the patient does reach remission or maintenance, they suggest following every 3 months with a PHQ-9, and then if this is the first episode, you can try to taper them at about 9 months. If it's a recurrent episode, you should consider a longer maintenance period. Go ahead, Cindy. The one other section in this guideline is when to refer. As with all guidelines, when to refer, the primary golden rule is if you're uncomfortable with the treatment or the diagnosis of the particular patient that's in front of you, it's always good to get some help. But if the patient fails a medication trial, if they have suicidal thoughts or psychotic symptoms, if there are some comorbid conditions that you're uncomfortable with, or there's an unclear diagnosis, if the patient needs any specialized treatments like MAOIs or ECT, those are all reasons to consider a referral for that particular patient. Go ahead, Cindy. So psychotherapy can be used, especially either as an adjunct to an antidepressant or alone if the patient is mildly depressed. And it's always good if you use psychotherapy to make sure that the patient is seeing someone who practices cognitive behavioral therapy or some kind of interpersonal therapy. You can use this alone if the patient is requesting it, or if the patient is pregnant. That's another good reason to do that. And you should consider. You can also consider the integration of other mental health resources as adjuncts. So some of the things we've mentioned, social service or other sources in the community. Cindy? Care management. If you have a care management team, you can refer folks for that. The things that they're helpful for are to make sure the patient continues with regular medications and that they understand side effects and the importance of drug adherence. That the care management team can help reinforce physician, patient, and family contact. They can help coordinate referrals and integration of mental health specialists, as well as consultation requests and self-management goals for patients, etc. Cindy? And then there's a gob of things on here on patient education, but you know, it's good to make sure the patient understands the importance of taking medication on a regular basis for antidepressants, that they understand the adverse side effects and what they should do if they experience any of those, that they understand that it takes a while to respond to the antidepressant treatment, and that it might take several visits to adjust and find the appropriate medication. And if there's any suicidal ideation, then the importance of reporting that. So that in general is an overview of that guideline. Did you want to stop for questions a little bit now, or wait to do that till the end?
I think we're going to wait until the end for that,
Okay.
Blake.
All right.
Hi guys, I was on mute. I did want to bring up something. So if somebody does have a question now, go ahead into the chat box and raise your hand. But what I wanted to pull up, because we didn't do that at the beginning, was a document to show you what these guidelines look like. So this is the guideline that Blake just went through. It is our best practice for depression management. Each one has similar sections to it. So first, we will always talk about the diagnostic pearls, the things that we need to be aware of for diagnosis. What are the treatment considerations? What are the referral considerations? Other treatment maybe that we don't think about, you know, the initial treatment ones are usually more about medication. Care management considerations, and then very importantly, patient engagement considerations. So we're going to see those sections in each one of these. At the bottom of the document is the link to the actual source document that our guidelines were created from. This is what the documents that are listed in your control panel are. So if you just download each of those best practice documents, you will end up with a copy of a document that looks like this for every single one of these that we're going to go over today. So, Valencia, did you have any questions?
No questions at this time.
Okay, that's fine. We're going to go on to heart failure next, and we're going to hear from Colleen about heart failure. So, Colleen, again, I'll progress the slides. You just let me know when you want me to move.
Okay, great. Thank you. So first, I'd like to talk about diagnostic pearls. When we think about patients with heart failure, there are really two classifications, and we want to use echocardiogram in order to determine that classification. Really, we're talking about heart failure with reduced ejection fraction or preserved ejection fraction. And the cutoff is the 40% ejection fraction. So if it's reduced, it's going to be less than 40%, and if it's preserved, it will be greater than 40%. Again, that must be confirmed on echocardiogram and should be considered if the clinical status has changed for a patient with heart failure and cardiomyopathy. When we think about imaging, we really want to consider non-invasive imaging for ischemia in patients with new onset heart failure. That would include things like non-invasive CT angiogram with stress testing. We can advance. As far as medical management, we want to be sure that we're doing a medication reconciliation at every visit, especially after care transitions. What we find often are comments and concerns when a patient has been admitted to long-term care facilities, hospital, and even emergency department visits. Patients may become very confused as to what they should and should not be taking, and it's important that we do that review at every visit. You want to verify the patient's medications are covered and that they can afford them and access them. Many of our patients are using mail order pharmacies and things like that, and so that may create greater affordability. However, access is sometimes a bigger issue. And often we can help to support them during that transition time while they're waiting for those medications to come in. One other thing that we want to consider is that all patients with reduced ejection fraction should be on appropriate goal-directed therapy unless contraindications are documented. So this would be beta blocker therapy. These are some examples. Again, ACE inhibitors or ARB therapy are the cornerstone of treatment, and really anytime a patient is seen with heart failure, we want to look at to be sure that they're on these medications, again, unless it's contraindicated. Diuretic therapy, often on an as-needed basis for symptom severity, is important, and aldosterone antagonists would be considered in patients with residual symptoms despite ACE inhibitors and diuretic therapy. Again, this is where we want to monitor renal function and potassium because they can be additive. And then the sacubitril and valsartan should replace ACE or ARB therapy in patients with cardiomyopathy. Hydralazine and nitrates are recommended especially for African Americans and those with intolerance to ACE and ARB therapy. We can advance. So moving on, as far as the medical management, when we're talking about treatment for patients with preserved ejection fraction, we should focus on hypertension management and diuresis for symptom control. These are medications that should be titrated for maximum tolerated dose. And again, during that time, we want to be monitoring for their renal function and potassium. All patients with coronary artery disease should be on a statin therapy. That's going to reduce their risk for MI. Then again, we want to consider an ICD for patients with ejection fraction that's less than 35%. At this stage, we obviously want to be referring that patient to cardiology. However, patients with symptomatic cardiomyopathy and a wide QRS noted on their EKG, they're going to be appropriate to recommend for biventricular pacing or resynchronization. We also want to be sure that we're having a discussion with our patients when it comes to palliative care. Often this is a late stage discussion and very difficult if it's happening at those later stages. It can be very challenging. So again, this is to try to give early referral and very clear expectations of the disease course. We always want to be counseling and supporting patients to quit smoking. And then again, these patients are going to have a higher risk for influenza and pneumococcus infections. And so we want to be sure that we are updating their vaccinations regularly. Can we advance the slide? Thank you. Other treatment considerations. Okay, so we want to consider their social determinants of health. So this is typically done through an assessment. Also, health literacy assessment is a good idea as well, and patient activation assessment to identify patients who would benefit from care management services. This is really to get a sense of what patients are truly understanding as far as their disease, getting them engaged in their care, and helping them to understand the long-term course of disease. Again, this is where we want to utilize care management and support staff to maintain communication with patients for engagement in their care. So these can be multiple conversations where we're discussing why and when they need to return for vaccination, or why and when they need to return to the office after they've been discharged from the hospital. Having patients with a secure understanding and expectation of when they should be seeking out care will help to reduce the overall costs and hopefully keep them out of the hospital. One other thing is identifying community or hospital resources to support the care management and function, as well as coordinate services. It's very important. Can we advance? So when we're considering referring patients, whether it be to a cardiologist, this is typically what we're talking about, we really want to use those parameters of the ejection fraction. And so referral to cardiology for heart failure with reduced ejection fraction, less than 40% confirmed on echocardiogram, it's really what the standard is. However, if we are feeling as though their course is more complicated, it is always okay to incite the specialists' care and support as well. So when you're doing this, you really want to establish a referral protocol between at least one cardiology and one primary care clinician. And the importance of that is understanding when that particular clinician would like to see that patient, when the referral should, the referral process should begin, and when that patient can be transitioned back over to primary care. Again, that typically has to do with comfort level between the two clinicians and really should be established early on. Can we advance, please? Thank you. Patient engagement considerations. This is extremely important, but what we want to be doing is really getting our patients as active and involved in their care as possible. So we want to be asking for their participation by encouraging them to exercise, to monitor their diet and medical regimen, as well as their weight. This is typically done through things like a daily weight log, where they're going to report any increase in weight by 3 pounds to the primary care physician, as well as referral to chronic disease management, self-management classes. Often those are found in the community, the surrounding community and hospital resources. We also obviously want to encourage our patients to quit smoking. So these are all very important. Can we advance as well? Okay, so hospitalization and transitional care. This is important because, one of the things that we hear so often is, my patient gets admitted to the hospital, their medications are changed around because they happen to be in a, in a bad place right now as far as their disease management goes. And when I have them returned to me, their medications have been changed. And it's extremely important that we are having a touch point on our patients shortly after they've been admitted to the hospital. Typically, this is going to be within 7 days, although 48 hours is sort of the standard that we're shooting for. We want to be discussing, the affordability of all the medications that have been initiated during hospitalization, as well as confirming that the patient understands those medications have now changed, or what those maintenance medications will be. And then again, we want to be reviewing the discharge plan for every patient so that there's an understanding as to what occurred throughout the course of their admission and what the next steps should be for the patient, not only so that there's continuity as far as communication from the hospitalist to the primary care provider, but also so that the patient has an understanding of what the expectations are for themselves and what may have changed since their admission. Next slide, please. Some of the things that we want to be aware of are some utilization metrics. So the wonderful thing is with our health exchange platforms, we are now able to track a lot of these things as far as the emergency department visits and hospitalizations, particularly with our heart failure patients that are at highest risk, depending on their frequency of exacerbation or admissions. This is where we can start to target these patients to create a more frequent touch point with them, as well as guide them toward community resources. One of the other things is the NQF 0081 and PQRS5 measure, which is an ACE inhibitor ARB therapy for left systolic dysfunction. The NQF 0083 PQRS8 beta blocker therapy for left ventricular systolic dysfunction, and the NQF 0079 PQRS measure 198, which is for left ventricular ejection fraction documented in the clinical notes. The beautiful thing about these is that we can track them, and these are typically going to be the patients that we'll be looking for these things on. Can we advance to the last slide? I think that's these are just the references that we've used. I will say primarily this comes from the most recent updated guidelines from the American College of Cardiology and the American Heart Association. And that's about it.
All right. Well, thank you, Colleen. We are going to move on to our last clinical topic, which is obesity, and Dr. Sobel is going to take that one on. So Dr. Sobel, take it away.
Thank you. And good afternoon, everyone. Now, as this webinar heads towards the final part, you're starting to think about the patients who you're going to be seeing in the exam room this afternoon. And one of them is going to be one of your patients who you've seen for years. And she's going to tell you that she's gained 15 or 20 pounds since last summer. And in 2 weeks, the 1st of August, they're going down to the beach, and she's not going to be able to fit into her bathing suit from last year. So she plans to be on a carrot and celery stick diet for the next 2 weeks. And if you can give her 30 fat burner pills, she's sure that she can get into her bathing suit. You and I both know this is not going to happen. Really, it's a process that has to be done correctly. And unfortunately, I think in medical school and a lot of our training, we spend a lot of time on hypertension, diabetes, heart failure, all kinds of topics. But with 1/3 of Americans overweight or obese, this is a major health problem. And unless we can face it the right way and do right by our patients, it just leads to frustration for us and for our patients. Too often we were taught, just give them a tear off one of those diet sheets and tell them to go out and exercise, and they'll lose weight. So really, we want to really measure the patients and follow them closely. We want to obtain levels of cholesterols, starting, also blood pressure. Interestingly enough, my partner became certified in bariatrics, and he'll constantly tell me about patients who are difficult to control, hypertensives or diabetics, and he's got them off of all their medications, and they're really basically being followed on diet because of the fact that they've lost all this weight and reduced their medication needs. All patients who smoke should be encouraged to stop smoking, and really it's a readiness to change lifestyle. You know, we just can't do this 30-day crash diet, because what happens is after 30 days the weight comes back on. Now, we don't need any fancy tools to assess these people. You have a scale, you have some measurements, and loss of weight to do that. Waist circumference makes up the way to measure for abdominal fat content. You don't need calipers or anything special specifically. And then patients who have a very high BMI, there's some sex-specific waist circumference cutoffs. And all this can be done in conjunction with BMI, and we'll talk about this in a little bit. Next slide. Okay, so our goal is to set up a weight loss therapy that the patient can live with, and ideally should be set up for a 10% loss from baseline. So you're a patient who's 200 pounds and overweight. If we can get 20 pounds off, it's a motivator. It begins to show the patient this can happen. You're not going to get a 200-pound patient who needs to weigh 140 down that 60 pounds at one shot. So that if we can get the patient to lose that 10%, it really motivates them to move on. A real weight loss should be about 1 to 2 pounds per week over a period of 6 months, and then we can play it out from there. And all this is done through a combination of low-calorie diet, increased physical activity, and behavioral therapy. We need to change how these people eat. If necessary, we can refer patients for further help with specialists. But we really want to support a self-management approach and ongoing monitoring. The patient's in your office for 15 or 20 minutes, but gone for the next month or so. And so we have the patient living in the community and having to fend for themselves. We want to help them how to deal with that. All smokers, regardless of weight status, should quit smoking. I guess it goes for all of the conditions that we talked about before. Older adults, seniors, it's a kind of a different process. Sometimes they need that extra weight to have on board if they get severely sick, and need to have those reserves if they're not eating or not doing well. Next slide. So the success of weight loss, and we all know about the yo-yo effect, really is based on diet, therapy, physical activity, and behavior changing the way that they live indefinitely and continue to watch what they eat. Drug therapy can be used, but safety and efficacy beyond a year really has not been established. And we'll talk about that again in a little bit. After 6 months of weight loss, we look at a weight loss stabilization program. We should be seeing these patients as frequently as we think we need to see them over the long term to encourage them, make sure they're doing all the right stuff. Too often we give them the diet, the exercise, and say, I'll see you back in 3 months, and that's just not going to happen. Prevention of weight gain should be encouraged, as we talked about, and if it does start to go up, they should either come in or reassess what's going on and go from there. Next slide. So when we talk about engaging the patient, we need to express empathy. We just can't say, you're fat, or you need to lose weight, or this surely should be easy. You don't want to argue with the patients. I mean, they have their own opinions on this. We need to resolve ambivalence and support them. So we need to ask them to talk about their weight, and we need to explore whether they're ready. Patients may just not be ready to lose weight. We can assess them using the BMI, the waist circumference we talked about, and ask them and see what's really driving their weight. We can advise them about the importance of losing weight, especially if they have complicating conditions like diabetes or hypertension. We need to agree on a realistic weight expectation. So, we're not going to lose 25 or 30 pounds to fit in the bathing suit by August 1st. Just not happening. And they don't need to get the 10% down necessarily immediately, but sometimes we see some dramatic improvements in health just by small weight losses of 5 or even 10 pounds. And that's a real motivator for patients to keep moving on. Now, what about weight loss surgery? I think that has to be carefully done with patients. Too often I've seen patients referred to the weight loss surgeon. They have a surgery, which, any surgery has its risk, including dying. And at the end of the day, when they're all done, their weight goes down not at all because they really weren't motivated to lose weight. And what they've learned to do is to get around whatever the weight loss surgery does, and they continue to be at that weight. So it really needs to be a down the line. They need to be motivated. They need to be able to show that they're capable of losing the weight, or at least trying very vigorously before we send them off to see your local surgeon. Next slide. So when do we refer patients? Well, we want to put them on a low-calorie diet, and as part of that, we need to look at how to reduce calories. We'd ideally like to lose 500 to 1,000 calories a day, which for some people could be easy. A 6-pack of Pepsi is 500 calories, maybe up 1,000 depending, somewhere between 500 and 1,000. So if we get them to give that up, that's fine. Patients may have ethnic foods that they eat, and so when we do the tear-off sheet and hand them a diet, it may not be the foods that they eat normally. Ideally, we'd like to get them to see a nutritionist. However, I fully realize that most insurances don't pay for the patient seeing a nutritionist, and we need to find an alternate method or some counseling, even in office. Some of your staff, if your medical assistants, can be trained and learn how to give low-calorie diets. Next slide. So physical activity, that's important. We can cut the calories down, but if we're not burning calories, if we're sitting watching TV all day, it's going to be a long, slow process. So physical activity ought to be thought of both as conditioning and as weight loss therapy. Patients may not have much physical stamina, especially if they're morbidly obese. And so we should encourage them to do some type of physical activity, 30 to 45 minutes, 3 to 5 times a week, would be a minimum. That physical activity may not be much in the beginning. For some of these people, it may be walking 1 or 2 blocks and coming back, and that may be it. But as the weight comes down and as their physical tolerance increases, ideally we can get them to move more, move faster, do more things, burn more calories. Next slide. Behavioral therapy. Some patients have real issues underlying their obesity. May be related to growing up, maybe finish everything on your plate, or otherwise children in China are starving. I mean, you've heard all this kind of stuff before. There may be issues of abuse or other things. And so some patients actually need to see a psychologist or a psychiatrist in order to get over the things that are aggravating or causing their obesity. Next slide. Pharmacotherapy. So, the patients all want the fat burner pills. Give me the fat burner pills so I can lose a lot of weight. They can work for patients and do work well. As we said, they should never be continued for more than a year, and they should never be continued unless the patient's committed to dietary change and exercise. At any point, if the patient's taking the medication but the weight's going nowhere, it's time to come off the pills. Next slide. The bariatric surgery. Again, this is a consideration only after we're sure that the patient's motivation and they've really attempted to lose weight by the low-calorie diet, by the exercise. Less invasive is always better, and we don't want to put our patients at risk for a surgery when we're going to get no benefit from it. Next slide. So here's the reference I use. This is a really interesting organization. They are one of the basic organizations of obesity medicine. They make all of their materials free and available, whether you belong to the organization or not. And so you can go to the website, which will be on the downloadable slides that you're getting, and you can go there and download lots and lots of great information, help for not only in your counseling, but also for forms and things like that that you need to counsel your patients. Thank you.
Had to go off mute there. Thanks, Dr. Sobel. You made me grin a few times during your presentation because I'm on the other end of that, maybe having that conversation about wanting to get in that swimsuit. So I will listen seriously to what you presented today. Okay, reducing unnecessary hospitalization. So this isn't purely a clinical evidence-based guidelines, but this is a guideline on some things that we need to be thinking about as practices in the community to try to keep our patients from being admitted or readmitted to the hospital. When we look at the cost of medical care and we look at what we're doing in practice transformation, we can make lots of small changes within the practice to the tests that we're doing, the drugs that we're ordering, the frequency with which we're seeing patients. But one hospitalization will knock out all of those savings if we're not really thinking about how to try to keep our patients out of the hospital. A hospitalization is just so much more expensive and, frankly, risky for the patient because we're putting them in a situation where they're actually exposed to more potential for problems. So We want to be thinking about how to reduce hospitalization in our patient population. And we're going to divide this into 4 areas. What we're going to do in practice in the community, what we do when a patient is in the hospital and then transitioning back, what we can do during that transition of care, and then in a little bit of long-term care setting, and what we want to be looking for when we're having to sometimes refer patients and their family members for placement in a long-term care facility. So first of all, in the community, our goal here is reducing potential for admission and emergency department utilization. So, the very first thing is evidence-based guidelines. We do want to make sure that we are using the most up-to-date evidence-based guidelines for the chronic conditions that our patients have. We want to make sure we're utilizing team-based care, because team-based care helps us to improve patient engagement. And if we engage patients in discussion and in responsibility for their care, they're going to do better. Again, I think Dr. Sobel mentioned this, they're with you for 15 minutes, but then they're home by themselves for the rest of the time. So they need to have that ongoing support. We can use things like structured pre-visit prep and daily team huddles to make sure that we are fully prepared when the patient gets there. We have the time to really deal with their issues that day, and we're not spending it hunting down test results that didn't come in. So using our team to have those structured pre-visit prep activities done and inform everybody on daily team huddles what to expect will really improve our interactions with our patients. We need to assign risk levels to our patients. We want to identify the people who are at a high risk or are at emerging risk, so at risk for exacerbation, because those are the patients that end up going to the emergency department and or the hospital. We could use monitoring and check-ins or reminders for patients who are high risk. We can use post-discharge follow-up within 24 hours of discharge or ED visit. Using those notifications that come from the Health Information Exchange are vitally important, especially for your ED visit patients. You want to know if they've been to the emergency room the day before and you weren't notified. You want to follow up with them and find out what's really going on. We want to remember our social determinants of health. People who are lacking food, support, transportation, these are all problems that are going to kind of be roadblocks in their way for really being able to focus on their health, because they're focusing on those more immediate needs and issues. So we want to be doing social determinants of health assessments and referring people to the community resources that can help them. And then finally, behavioral health needs, depression screening and intervention, so important. People who are depressed tend to not do as well from a health perspective overall. And so then they end up with an exacerbation of their condition because they're not really following their treatment plan, and there they are in the ED yet again. So when you're treating patients in the community, these are the types of things, the evidence-based guidelines, team-based care, assigning risk levels, post-discharge follow-up, social determinants of health, and depression screening and intervention that will help you keep your patients from going to the ED or using the hospital. So in the community, the other thing we want to think about is appropriately using home health and community-based resources. Know what those are in your community. You need expanded office hours. Have you assessed whether your office hours meet the needs of your patients? If you're there during certain hours, but what they need are different hours, maybe we're not quite meeting their need. And when we're not there, what are we doing? Are we using, do we have a actual formal agreement with a urgent care center that will take on your patients and treat them the way you want to? Or are we kind of leaving it up to the luck of the draw? 24/7, 365 access to clinicians. This doesn't mean that you have to have your office open 24/7, but it does mean that there needs to be some method by which calls that come in after hours are properly vetted by a clinical triage person and then gotten to one of the clinicians in your practice who can then remotely view your EHR and deal with that patient's problem. 24/7 access doesn't mean we have an answering service and when people call at 8 o'clock at night, we just tell them to go to the emergency department. It is really creating that call system where you or someone within the practice can be talking to that patient and properly counseling them on what to do. Again, patient and family engagement and education, so important as part of the practice in the community. Assessing health literacy, the patient's ability to understand their disease. and their activation, which is their readiness to act on their health. Are they really prepared and able to deal with what you are asking them to do as part of their treatment plan? You want to use multiple methods of education. So in-visit resources, so tear sheets could be something. If you have a nurse or medical assistant who you can train up in a specific area, they can then reinforce that education with the patient. Your patient portal can be used to provide people with links to education and links to other resources online. Patient self-management tools can be a very effective thing with patients. If we're giving them homework to do and they have to bring that log or diary back to the next visit and they have to pay attention to it, they have more chance of following through. And sure, not everybody will keep their log up, but if we don't offer it and try it, nobody will keep their log up. So we want to always be trying with these different types of resources and interventions. And then finally, referral to community resources. Know what's available in your community. Know what's available from your area agency on aging, your local senior centers, your local hospitals, so that you can refer patients to those programs. Appropriately using specialists, creating care compacts with specialists. In other words, having that conversation with the specialist if you're primary care, or with the primary care if you're a specialist, so that everyone knows when should I be referring, who should I be referring, and how should I be referring. And you've really developed a back and forth, truly coexisting co-management relationship with those specialists. And finally, use population health management. Proactively identify and address the gaps in care before problems arise. You know, if you're managing a diabetic patient and they haven't had an A1C drawn in 12 months, that's a problem. If your EHR can help you to identify those people who have gaps in care to get it done on time, that's going to improve the patient's outcome because it's going to speed up your intervention into any issues that are occurring. So that's what we want to do in the community. Those are evidence-based practices that help us to keep our patients from getting admitted. But once they get there, what do we do? These are actions the hospital can take to reduce potential for readmission. Now, understandably, many of the hospitals that we deal with have hospitalists, and maybe you, as the community physician, aren't the attending for those cases. And so some of these things are things that the hospitalists need to do. And so we need to work with our hospitals and identify what are the protocols that the hospitalists use while patients are there. Really important stuff, though, is to, of course, educate the patient throughout their stay about their diagnosis and engage the patient and family in that. We frequently quote the statistics that patients only remember 20% of what we tell them in an office visit. Well, the same goes for a hospitalization, because at that point, they're even further out of it. And so we have to keep reviewing and over-educating to make sure people get the information and retain it. We always should be doing a follow-up within 7 days of discharge of our patients. So again, use your health information exchange, the DIN or CRISP, to identify your recent discharges and get those people in. Even better, work with your hospital to call you before they're discharged to set up that appointment. And have appointment times on your schedule available for those quick turnarounds. Because honestly, if we could follow up within 1 to 3 days, that would be even better. But 7 days should be the most. While they're in the hospital, we want the case managers there to schedule post-discharge testing and services, not just give them a list that says you should do this, but actually go in and schedule them for you. They need to give the patient a written discharge plan and use TeachBack, which we all need to do when we're working with patients so that we ensure that they understand. We want hospitals to expedite the transmission of discharge summaries to outpatient providers. And we want them to call to reinforce the discharge plan 2 to 3 days after discharge, especially for those at high risk of readmission. And that leads to the last one, assign a risk score for readmission. I don't know all hospitals. I know PRMC, where most of my practices are, they do assign a risk score for readmission. It's right there in the EPIC system. And that community view that community practices who aren't on EPIC can see has that risk score right on their status tab. So it's an important thing to look at and to understand how high at risk is this patient for readmission. Okay, post-discharge. So this is transitional care management or transitions coaching. We do want an evidence-based plan of care. So really we want a transitional case manager to be looking at the hospital assessment while they're in the hospital so that they know what needs to be done afterwards. Transitional care management should provide regular home visits with available telephone support. We know this is something that works. It's certainly something you'd have to work with your hospital on to provide. We need to focus holistically on the patient's needs. So, with these high-risk patients, we really do need to be looking at all those social determinants of health and making sure we're sending referrals to the right places. We want to emphasize early identification and response to healthcare risks. So, one of the most important things to educate the patient on as they're leaving the hospital is, what are the early warning signs that you're not actually getting better anymore, but maybe you're regressing? And we want to quickly act on those with a call to the primary care or specialty physician as appropriate. We want to actively engage both patients and caregivers, because whenever we involve the caregivers, we have that extra level of education and support going out, another person that's being educated and communicated with. Of course, communication is important, and working collaboratively with the hospital to create this. Very few practices can do transitional care management all on their own. You're going to need to work with your hospital, your local hospital, to figure out what it is they do, what it is you can do, and how you work together on that. And then finally, we include this just to give you an idea of things that, again, in the literature have proven to be pretty effective in reducing the number of acute care admissions coming out of long-term care. Also realizing that for the most part, our community physicians are not attending their own patients in nursing homes and skilled nursing facilities. It is the nursing homes physician who's doing that. So these are things, though, that have been proven in the long-term care setting to be successful. So if you find a nursing home, a skilled facility that has these things in place, these are things that can be proven to be highly reliable. So using standardized programs, there are several of them. Interact is one, the SBAR tool is another, where they really systematically assess patients' condition and what the intervention or reaction should be. Physician coverage, which includes expanding on-site hours and consistent on-call coverage so that they don't have to wait 4 days for a doctor to come back in and see the patient. EHR and Q-shift change staff huddles so that the unit manager can identify early warning signs. So these huddles don't normally involve the physician, but they involve the nursing staff, and it's that Q-shift huddle to make sure everything's being passed along. But it helps the unit manager to identify problems earlier so that the physician can intervene. Weekly meetings that help them to do basically case review meetings to discuss each patient that was transferred out and what could have been done differently, so maybe they could do it differently next time. Seeing a mix of nurses that include those with hospital experience to address the kind of growing acute need of this population. And then a system for regular updates on patients that you send to these settings. And I think that as a community practice, that's probably one of the more important things. If you are going to be overall still responsible for this patient, yet not being able to see them routinely in that setting, there's got to be some kind of good communication back and forth between the long-term care setting and the community provider in order to have continuity of care and overall quality of care. Our reference for this particular set of items is a document called Effective Interventions to Reduce Rehospitalizations. It does include 15 different interventions that cover all different levels of care, and that's why we tried to reflect the 4 different levels in the presentation here. Okay, so we're right up at 1, but if you'll hang with me, we have 1 polling question. So Valencia, would you like to launch that?
Certainly. Thank you, Cindy. So based on today's presentation, my practice will identify and implement 1 evidence-based guideline in 2018. My practice is unsure if we can implement 1 evidence-based guideline in 2018, or my practice does not plan to implement 1 evidence-based guideline in 2018. So we have about half voted so far. And Cindy, it looks like we're at 100% that say my practice will identify and implement 1 evidence-based guideline in 2018.
Well, I love you guys. We appreciate that, and your practice advisors will be talking with you about that to try to make sure that we can meet that commitment. That's an excellent commitment. I'm going to ask Valencia to leave this open for just a little bit longer, just in case you didn't get all your handouts downloaded, because I really, really, really want you to download these handouts so that you will have the information available. We can help you to use these as a simple checkoff to say, we do that, we do that, we don't do that. Identify the things you don't do, and let's talk about how we can get them implemented. I thank you all for your time and attention today. Please do reach out if you have any questions. And again, we'll leave the line open for just a little bit longer. Thanks so much to everybody.